The paperwork was the first thing she touched when she arrived that night. Not a patient, not a chart. A stack of intake forms, still warm from the printer, sitting at the edge of the station desk like an accusation. Her name was Claire Maddox. She was 34 years old. She worked the overnight surgical floor at Ridgemont Memorial in Eastern Virginia, a mid-sized regional hospital that ran its administrative hierarchy the way older institutions tend to, with immense seriousness about procedure and almost no seriousness at all about what the procedure was actually for. Claire had been there for 2 years. Before that, she'd been somewhere else entirely, but on any given night shift at Ridgemont, no one would have known that by looking at her. She arrived with her badge clipped to the left breast pocket of her blue V-neck scrubs, her blonde hair pulled into a low, practical bun. A few strands loose near her temples from a wind that had cut through the parking lot, and a silver watch on her left wrist that she had not taken off in years. Her eyes were a quiet blue-gray. Her face showed the particular kind of tiredness that belongs to people who sleep well enough but have been getting up in the dark for a very long time. She was not the kind of person who made an entrance. She set her bag down, picked up the forms, and started reviewing the shift turnover. The ER had flagged a patient approximately 90 minutes before her arrival. Male, approximately 60 to 65 years old. No identification found on his person, no phone, no wallet, no emergency contact information of any kind. He had been brought in by a paramedic crew responding to a 911 call placed by a convenience store clerk who said the man had walked in looking gray and had gone down behind the candy display near Register 2. Field notes described him as agitated and uncooperative. One of the receiving physicians had written a notation that used the phrase altered mental status, possibly related to intoxication or psychiatric condition, which was the kind of medical language that, in a busy hospital late at night, functioned less as a diagnosis and more as a way of moving a difficult case to the lowest possible rung of urgency. The patient had been given a bed, he had been given fluids. He had not been given a name because he hadn't offered one, and the staff who had tried to get one from him had recorded his behavior as resistant and combative before moving to more cooperative patients. He had been assigned the placeholder ID of John Doe and filed under a designation that the hospital's triage system technically labeled pending evaluation, but which functionally meant wait. Claire read the file twice. She set it back on the desk and walked down the corridor to Bay 12. If you've ever wondered why some people in overwhelmed institutions stay still while everyone else is moving, keep watching. Because what happens next in Bay 12 is where this story actually begins. The man in the bed was not asleep. He was lying on his back with his eyes partly open, staring at the ceiling with the fixed, effortful concentration of someone trying to stay conscious. He was large through the shoulders in the way that spoke of a body that had once been kept deliberately and relentlessly strong. His hands, folded over his abdomen, were calm. His breathing was not. It was shallow in a specific way, not distressed, not labored in the dramatic sense that draws attention, but controlled, disciplined, as if he had been taught long ago how to breathe through pain without showing it. Claire stood at the foot of his bed for a moment. She noted the color of his skin, which had the particular grayish undertone that does not belong to cold or fear or intoxication, but to something else entirely. She noted his lips. She noted the way his jaw was set. She noted that his left hand, despite the apparent calm, had the very faintest tremor. She pulled on gloves and moved to his side. "Sir," she said, "my name is Claire. I'm going to check your vitals." He turned his head toward her. His eyes, when they focused on her face, were not confused. They were very tired and they were in pain, and they were watching her with the kind of attention that comes from someone who has spent a significant portion of their life having to accurately read other human beings at speed. "All right," he said. His voice was low and steady, not the voice of someone who was intoxicated, not the voice of someone experiencing a psychiatric break. Claire noted that too. She ran his pressure manually, which was not standard practice at that hour when the automated cuff was already attached. She did it because the automated reading on the chart had flagged as unremarkable, and the man in front of her was not unremarkable. He was 84/58, with a pulse rate of 104. She pressed 2 fingers gently to his abdomen, watching his face rather than her hands, and saw the faintest tightening around his eyes. Not at the place where the EMTs had noted the patient complained of pain, but 3 inches to the left and approximately 2 inches lower. She straightened. She left the room without explaining what she was doing, which was protocol adjacent if not protocol perfect, walked back to the station and pulled up his imaging history from the brief scan the ER team had ordered. Then she picked up the phone and called the on-call general surgeon. "Doctor," Marcus Holt answered on the 3rd ring with the particular tone of a man who had been doing this long enough to resent being woken at 2004-7 in the morning. He listened to what Claire said. He said, "The ER already cleared him." She said, "The ER ran an abdominal view without contrast. I believe there's splenic involvement and I'd like you to come down." There was a silence. Then Holt said, "Nurses don't order imaging." Claire said, "I'm requesting that you order imaging, doctor. I'm giving you my clinical observation and I'm asking you to evaluate the patient in person." Holt came down. He looked at the man. He ordered the imaging. When the contrast CT came back 41 minutes later, it showed a grade 3 splenic laceration with active extravasation. The man was in the OR within the hour. By 5:30 in the morning, he was out of surgery and in the ICU, alive. By 7:00, Claire was in the shift administrator's office. The office belonged to Glenn Ferris, the hospital's director of nursing operations. A man whose entire professional identity had been constructed over 22 years around the principle that the institutional hierarchy of Ridgemont Memorial existed to protect itself from exactly the kind of thing Claire had just done. Ferris was not a physician. He had not been at the bedside in years. He had gray hair cut close, a pressed shirt, and the practiced neutrality of someone who had learned to conduct difficult conversations by making the other person feel as though they were already guilty of something. "You contacted Dr. Holt directly," Ferris said. "It was not a question." "I did," Claire said, without escalating through the charge nurse or the attending physician of record. The attending of record had left the building. The charge nurse was managing a code in Bay 7. "I made a judgment call based on clinical findings." Ferris wrote something on a yellow legal pad. The writing had the deliberate quality of a gesture rather than note-taking. The ER team evaluated that patient and found no indication of acute surgical emergency. "The ER team ran imaging without contrast at intake," Claire said. "The laceration was not visible on those images. It became visible when contrast was used." "You requested contrast imaging. I requested that Dr. Holt evaluate the patient." Dr. Holt ordered the contrast imaging. Ferris set his pen down. "Claire, you've been here 2 years. You understand that there are systems in place for a reason, that those systems exist to protect patients as well as staff. The patient would have gone into hemorrhagic shock by morning if those systems had been followed as written," Claire said. The silence that followed was the kind that precedes the decision that has already been made. Ferris told her that pending a formal review, she was suspended from floor duties effective immediately. He told her that the hospital's legal team had advised that any clinical overreach that bypassed standard escalation procedures represented an institutional liability. He used the word liability 3 times in 4 minutes. He told her she would be notified of the date for a formal disciplinary hearing and that she was strongly encouraged to bring representation. Claire walked out of that office at 7:22 in the morning. She walked to her car in the parking lot. She sat in the driver's seat for approximately 4 minutes, not crying, not making phone calls, not doing the things people do when they have just been formally humiliated and stripped of their livelihood. She sat with the particular stillness of someone who has been in worse positions than this and survived them with their core intact. Then she drove home. The formal notice arrived 2 days later. It cited violation of escalation protocol, failure to obtain charge nurse authorization for physician contact, and conduct inconsistent with Ridgemont Memorial's established clinical governance framework. The notice included a line suggesting the hospital was prepared to recommend termination pending the outcome of the disciplinary hearing, which had been scheduled for the following Tuesday in Conference Room B on the administrative level. The hearing convened at 9:30 a.m. Ferris was there, seated at the center of a rectangular table with 4 other members of the administrative team, including the chief medical officer, Dr. Dockery, Patricia Wren, who was technically the most senior clinical authority in the room and who had arrived 6 minutes late and was still reviewing papers when the session began. To Ferris's left sat the hospital's legal counsel, a man named Alan Briggs who wore an expensive watch and the kind of measured smile that communicates procedural advantage. Claire was seated across from them, alone, on a single chair positioned slightly away from the table, a placement that was either accidental or was not. She was wearing the same silver wristwatch, her scrubs were freshly laundered, her hair was in the same practical bun. Her expression, if you had been in that room and watched her face, was composed in a way that did not read as defeat, it read as waiting. Ferris opened the session with a recitation of the procedural violations as outlined in the notice. He presented them with the even cadence of a man who has organized his presentation into 3 parts and intends to spend approximately 40 minutes moving through them at a pace that suggests thoroughness while eliminating room for interruption. He referenced the hospital's clinical governance policy 11 times in the first 15 minutes. He referenced patient safety twice, and only in the context of how protocol violations endangered it, not in the context of the actual patient, who was alive and recovering in the ICU 12 floors above the room in which this hearing was taking place. Claire listened. She answered questions when they were put to her precisely and without elaboration. When Briggs asked whether she had received and signed the acknowledgement form confirming her understanding of the hospital's escalation protocol, she said yes. When Wren asked whether she understood the risks of bypassing the charge nurse authorization step, Claire said, "I understand the protocol. I also understood that following it as written would have cost the patient significant blood loss and possible death before the next authorization cycle could be completed." Wren wrote something on her notepad and did not respond. At 9:41, Ferris was midway through the second section of his presentation when someone knocked on the door. Knocked is perhaps the wrong word. The sound was a single, measured impact, not an apologetic tap, not an aggressive pound, but the kind of knock that communicates that the person behind the door does not intend to wait for an invitation. The administrative assistant, a young woman named Dee, who was stationed just outside the room, opened the door herself rather than waiting to be asked, and afterward, when colleagues pressed her on what she had seen, she said only that something about the way they were standing in the hallway made her feel that opening the door was the correct thing to do. There were 12 of them. They were not in uniform. They were in civilian clothes, slacks, collared shirts, a few in jackets. But the way they stood in the corridor outside Conference Room B, arranged without apparent coordination into a loose formation that nonetheless had structure, told a particular kind of story to anyone paying close enough attention. They ranged in age from the mid-40s to what appeared to be the mid-60s. Several of them had the particular physical bearing that a certain kind of intensive training leaves permanently on a body, not bulk but economy, posture, the specific quality of a person who does not occupy space accidentally. More than one had visible scarring on the hands or neck or jaw. None of them were looking around the room with curiosity. They were looking at one person. They were looking at Claire. The man who entered first was perhaps 52. His name, which would emerge over the next 40 minutes, was Garrett Bryce. He had a wide, calm face and the kind of stillness in the eyes that accumulates over years of watching things happen and surviving them. He set a leather folder on the table without being offered a seat, pulled out a chair, not adjacent to Claire's isolated chair, but at the table on the same side as the administrators, and then remained standing. Ferris said, "This hearing is closed to outside parties. I'm going to need—" "We're not outside parties," Bryce said, his voice carried without volume. "We're witnesses, and we have documentation." He opened the leather folder and slid a stack of papers across the table to Ferris without making eye contact with him. The other 11 men had filed in behind him. They arranged themselves along the back wall, standing in a row that was neither aggressive nor casual. It was simply present. The documentation Bryce had laid in front of Ferris included a signed statement from the patient in the ICU, whose name was Thomas Edward Calloway, retired United States Navy Master Chief Petty Officer, who had served 3 decades in naval special warfare and who had declined to identify himself to any hospital staff, not because he was confused or unstable, but because he had been living off the grid by deliberate personal choice for the past 6 years and had not carried identification for most of that time. The documentation also included letters from 4 former commanding officers, a medical statement from the surgical team confirming that the clinical intervention ordered by Dr. Holt had been directly and conclusively life-saving, and a single sheet of paper typed on plain white stock that bore the heading Statement of Collective Testimony and was signed by all 12 men in the room. Ferris looked at the papers. He looked at Bryce. He said, "The patient's identity doesn't change the procedural circumstances under which we'd like to speak," Bryce said. "We'd appreciate the opportunity to do so before you continue." There was a moment. Wren, who had stopped writing, looked at Briggs. Briggs was reading the top page of the documentation. His measured smile had achieved a quality of absolute neutrality. Bryce did not ask for permission again. He began speaking, and what he said, in the precise, non-theatrical language of a man who has testified before more consequential audiences than a hospital conference room, was this: Thomas Calloway was their commander. He had led their team through 3 combat deployments across 2 theaters. He had made 17 tactical decisions that other men would have hesitated at and been right about all 17 of them. He had carried 2 of the men in this room out of situations that should not have been survivable, and he had done it without recording it anywhere, without seeking recognition, and without speaking about it after. He had retired quietly and chosen to live on his own terms, which was his right, and which the men in this room respected because they had watched him earn it. They had maintained contact with him by methods that suited his preference for privacy. They had been located and contacted by the hospital's ICU social worker after Calloway had finally agreed to share 2 pieces of information: the name of the town where he'd gone to ground, and the frequency of a radio channel on which one of the men in this room monitored for exactly this kind of emergency. Then Bryce stopped. He looked for the first time not at the administrative table but at Claire. "We want to talk about the nurse," he said. Ferris said, "The disciplinary proceeding concerns Ms. Maddox's conduct, not. Her conduct is exactly what we want to talk about," said the man standing third from the left against the wall. He was older than the others, somewhere in his early 60s, with a jaw that had been broken at some point and healed at a slight angle. His name, it would emerge, was Donald Sharp. He had the voice of a man who had given orders in places where orders had to be given once and only once. "We want to talk about what she saw." The room was quiet in a way that had stopped being procedural and started being something else. Bryce opened the folder again and produced a second document. It was a service record, heavily redacted, as such records often are when the work documented in them took place in locations and under circumstances that official history prefers to describe obliquely. But the portions that were legible showed a name, Claire L. Maddox, and a service designation that read, Hospital Corpsman, HM2, attached to Naval Special Warfare Command, with operational deployments marked in 3 locations by black ink redactions and a commendation notation that had not been fully concealed. Claire had not moved. Ferris was looking at the document. He was looking at it the way people look at information that is reorganizing something they believe they understood. "She was our corpsman," Bryce said, "not attached to our specific team. But she deployed with Allied elements and we shared FOBs, field surgeries, and, on 2 occasions, she was the only medically trained person present during contact situations where we had casualties." He paused. "She managed penetrating trauma in a forward position under fire. She is not a nurse who got lucky with a sick patient. She is a combat trauma specialist who recognized internal hemorrhage because she has seen it in conditions where there was no imaging, no surgeon on call, and no time. She recognized it because her hands know what it feels like and her eyes know what it looks like, and she has made those same clinical decisions before in places where being wrong meant someone died on the ground." Wren had stopped pretending to take notes. She was looking at Claire with the expression of someone recalculating a figure they had been confident about. Donald Sharp spoke again from the wall. "The notation in your record says she was combative," he said. He was not speaking to Ferris. He was speaking to the room. Chief Calloway, 63 years old, unidentified, possibly intoxicated, probably psychiatric. He let the words sit there. He was lying there dying because nobody looked long enough, except her. He nodded toward Claire without ceremony. She looked. She understood what she was looking at. And then she did what needed doing, the same way she always did. The man at the far end of the wall, younger than the others, perhaps 45, with a long scar from his left earlobe to the hinge of his jaw, said, "We asked around about her before we came in today. The people she works with say she never talks about her service, not once. 2 years here, and none of them know. She doesn't use it for leverage. She doesn't use it to claim authority she hasn't re-earned in this context. He paused. She just works. Claire was watching the table. Bryce laid one more document on the table. It was a letter, handwritten, on lined paper. It had been written that morning in the ICU by Thomas Calloway. Bryce did not read it aloud. He slid it to Wren. Wren read it. She set it face down when she finished, slowly, and then pressed her palm flat against it for a moment, in the way that people sometimes do when they have read something that requires a physical response. Ferris said, "I want to be clear that this hearing concerns a procedural, Dr. Ferris." Wren's voice had changed. It was not hostile, but it had the quality of someone reasserting seniority without making a display of it. "I think we should pause for a moment." There was a pause. In that pause, the administrative architecture of Conference Room B, the single chair positioned apart from the table, the legal counsel with his measured smile, the 11-page procedural citation. The word liability, used 3 times, did not collapse dramatically. Institutions rarely collapse dramatically. What happened instead was quieter and more complete. The room reorganized around a truth that was larger than its paperwork, the way water reorganizes around a stone that has always been there but was not visible until the surface cleared. Briggs set down his pen. He had been looking at the redacted service record for the past 3 minutes. He set it down and then aligned the edges of the document stack on the table in front of him with the particular precision of a man who has nothing else to do with his hands. Wren looked at Claire. "I'd like to hear from you," she said. Claire raised her eyes from the table. "About what?" she said. "About what you saw when you walked into Bay 12. Claire was quiet for a moment, not calculating, organizing. When she spoke, her voice had the same quality it had at 2047 in the morning when she had told Holt to come down and look at a patient who everyone else had already categorized and set aside. It was not dramatic, it was exact. His color was wrong, she said. Not wrong for a psychiatric presentation, wrong for volume. His pressure was compensated, which means it looked normal until you ran it manually and got beneath the automated read. His abdomen was guarding on the left, but he had the pain tolerance of someone who had trained extensively not to show pain, so the guarding was minimal unless you looked for the jaw response rather than the verbal response. His breathing pattern was controlled in the specific way that people control their breathing when they're managing significant internal pain and have been trained to do it quietly. She paused. And his left forearm. When I moved to check his IV access, his sleeve shifted. He has a unit tattoo, partially faded. Naval Special Warfare Command. The design is specific. I recognized it because I spent 14 months in proximity to the men who wear it. No one spoke. That detail didn't change my clinical reasoning, Claire said, but it told me that the notation in his chart about combative behavior and psychiatric presentation was almost certainly inaccurate. Men who come out of that background don't present that way without a physiological reason. So I went back to the clinical picture, and the clinical picture said internal bleeding. So I called Holt. She stopped. She had said what she had to say. She was not asking for applause. She was not asking for validation. She was doing the same thing she had done in Bay 12 at 2047 in the morning and in places before that in worse light with fewer instruments. In more immediate consequences, she was giving an accurate account of what she saw and what she did about it. Ferris sat with his hands folded on the table. He was not a cruel man. He had spent so many years administering a system that the system had become indistinguishable from his own judgment. And the particular humiliation of this moment was not that he had been outranked or overpowered. It was that he had looked at Claire for 2 years and had not seen her. Not because she had hidden, but because the institution he managed only noticed the shape of a person when they violated the paperwork surrounding them. And Claire had spent 2 years doing her job so cleanly and so quietly that the paperwork had never caught her attention at all until the night she saved a man's life, and it caught her in the wrong way. He said, "I'd like to request a brief recess." The recess lasted 16 minutes. When the hearing reconvened, Wren spoke first. She said that, in light of the evidence presented and the clinical record of the patient's outcome, the hospital would be withdrawing the procedural violation citation. She said that the nursing staff's escalation to the on-call surgeon had been, upon review, consistent with the spirit of the hospital's patient safety mandate. She said that the formal notice of pending termination would be rescinded and that Ms. Jass Maddox was to be reinstated to full active status immediately. She said these things in the measured, precise language of institutional medicine, but she said them, and the room recorded them. Ferris did not speak during the reconvened session. He wrote on his yellow legal pad. The writing, this time, appeared to be actual notes. Bryce thanked Wren. He gathered his folder, nodded to the men along the wall, and they began, without fanfare, to move toward the door. They had come here as a group, and they were leaving as a group with the same economy that characterized everything they had done from the moment they arrived, which was no wasted motion, no unnecessary words. No theatrical gestures toward an audience that didn't exist. At the door, Bryce paused. He turned back toward the table, toward Claire specifically, and said something that the administrative staff would not recall verbatim, but would all remember in substance. He said, "For what it's worth. He asked us to tell you. He knew it was you before you finished checking his pressure. He said he recognized the way you worked." Claire looked at him. There was a long moment in which her face did the particular quiet thing it did when she received information that cost something internally to receive. Then she said, "How is he?" "Ornery," Bryce said, "which is normal." He left. The 11 others filed out after him. The room was quiet in the way that rooms are quiet after something irreversible has taken place inside them. Not silence born of emptiness, but the kind that settles when the structural question has been answered and no one quite knows how to return to the ordinary business of the day. Claire remained seated for a moment after the rest of the room began to collect its papers and close its folders. She was looking at the table. Her left hand rested near the wrist, fingers loose, and she was turning the silver watch slightly, the way people turn familiar objects when the world has just reminded them of its weight. She stood. She picked up the bag she had set against the leg of her chair when she arrived. She walked to the door. In the hallway outside Conference Room B, the fluorescent lights ran at the particular flat frequency that every hospital corridor carries regardless of the hour. A kind of permanent institutional daylight that erases morning and evening into the same managed brightness. The administrative wing was already resuming its ordinary traffic. Clipboard passes, badge swipes, a rolling cart of linen moving past the elevator bank. None of it was looking at her. None of it knew. But 12 floors above in the ICU, Thomas Calloway was in a bed that he would occupy for the next 9 days, breathing with deliberate control because old habits do not easily suspend themselves. Watching the door the way he had spent his career watching doors. And alive because a woman who had learned her craft in conditions that this building would never witness and that no form in this building's filing system would ever adequately capture, had looked at him for 30 seconds and understood precisely what was wrong. She had not done it to be vindicated. She had not done it to claim credit. She had done it because the alternative was unacceptable, and the calculus of acceptable versus unacceptable was something she had completed a long time ago in a different kind of room, in a different kind of uniform, with different stakes in the same eyes. The elevator doors opened. She stepped inside. She pressed the button for the ground floor. The doors closed. The car descended. There are institutions that mistake process for purpose and authority for judgment. And there are people inside them who know the difference so deeply it has become structural, baked into the reflex, woven into the way they stand at a bedside in the middle of the night and look at a man that everyone else has already decided not to see. Those people rarely announce themselves. They show up. They do the work. And sometimes on a Tuesday morning in a conference room with fluorescent lighting and a yellow legal pad, the weight of what they carry becomes briefly fully visible. Not because they chose to show it, but because something required them to. Then they take the elevator down and go back to work. If this story stayed with you, and I think you know why it did, share it with someone who believes that the quietest person in the room is never the least important one. And if you haven't already, take a moment to subscribe. The best stories here are the ones that don't announce themselves either.